good morning, everybody. Yo, you guys hear me fine or no?
Yes.
You hear me all right?
See if that
Yeah. I agree. And then that's a 7 hour.
Yeah, I didn't really want to be done today. First of all, when I make it.
And then emotion. Yeah, that's gonna be too much. I'd rather just go home.
Yo, I don't know if Jeremiah, you sent the lecture out to everybody right there. So I sent Jeremiah the lecture. I'll email it to you guys if you guys want to open up your laptop a little bit. I have some slides on here about like oral facial pain and how to manage that, but I think Dr. Davis is his name. He's going to lecture you guys on that. So when we get to that part of the lecture, I'll just skip over it because I didn't know until today that I wasn't covering that as well. So today we're going to be discussing temporomandibular joint disorders and how to properly manage them. I feel like before we start that though, we just want to go over the basic anatomy because it's important to understand how that joint, just like your elbow joint, your knee joint, how it functions and just kind of the basics about it as well. So can anybody tell me what the main function of the TMJ is? It's not like a trick question. You just.
What is the question?
What's the main function of your TMJ?
Open and close your mouth.
Yeah, so it facilitates movements of your lower jaw. Allows a range of movements, whether it's translational movements. Does anybody know what translational movements are? Yeah, so translational is protrusion and retraction. So if you're sticking your lower jaw out and you're bringing it back in. And then it also allows for lateral deviation, like Julian was saying, and then rotational movements. By rotational movements, we mean elevating and depressing your jaw, basically opening and closing. So we have two movements. We have translational movements, which is when you're protruding your lower jaw in and out. And then we have rotational movements where you're opening your jaw, bringing it up and bringing it down, elevating and depressing. So if you look at the image here, this is kind of your basic anatomy of your TMJ. You guys can see it on the slide. I'm not going to go over it with you guys, but you can see it here. So it's important just kind of understand, the anatomy. That way, if you're seeing a patient, you understand what the ramus is, where the TMJ disc is supposed to be. That's the TMJ in its natural position. The TMJ disc, in its natural position. And then sometimes there are discrepancies of that disc, whether it's anterior or posterior to the condyle, and that can lead to certain TMD, what we call temporomandibular derangements. Okay? So this is just kind of some more anatomy of the TMJ, as you guys can see, on the slide. And some functions of, that this anatomy assists with is obviously chewing, swallowing, facial expressions, even breathing. If people have, problems with their TMJ, that can often lead to obstructive issues like breathing as well. Like we said earlier, protrusion and retrusion, or excursive movements of that lower jaw. Can anybody tell me what the functions of, what muscles are involved with the TMJ? Just off the top of your head.
medial lateral pterygoid. Medial lateral pterygoid.
Yeah, so you have your pterygoids, you have your masseter, your temporalis. So you can kind of see it here on this, image. So I want you guys to take a good look at the musculature that's around that. See my mouth showing? Yeah, that's around kind of that joint area. So we talked about the temporalis, the pterygoid, and the masseter. So if you're looking at that masseter, originates from what we call the arch, the zygomatic arch. You can kind of see where I'm hovering there. And it has a bunch of layers, and it inserts into the mandible, on the side part or the lateral surface, which is right here. Does anybody know what the primary task of the masseter is?
Elevation.
I heard that something. Yep. Primary task is to elevate that jaw. What's it innervated from?
It's temporal.
So what nerve kind of stimulates
what nerve?
that? So we said the trigeminal nerve, and if you want to get more specific, there is a certain branch, the masseteric branch of that trigeminal. Okay, and then we have the temporalis, which is the big muscle on the side of your skull here. Okay, that originates from the fossa of the temporalis and the medial face of the zygomatic process. So right here, so the fossa of the temporalis, which is behind the big muscle, and the medial surface of that zygomatic process, and it inserts on the coronoid process of the mandibular process. Okay. Does anybody know what the function of the temporalis is? Yeah, elevates the mandible. So we said the masseter elevates, the temporalis elevates as well. And what's it innervated by? The third branch of the trigeminal nerve. Right? Okay, so we have our lateral pterygoid as well. It consists of an upper and a lower head. And what's the function of the lateral pterygoid? Yeah, what else? Yeah, it depresses the mandible, yep, and it protrudes as well. So we said the temporalis and the masseter. What do we say those do? It elevates the mandible, right? Now we're talking about the lateral pterygoid that protrudes and depresses the mandible. Okay, we have the medial pterygoid as well. So while you're contracting bilaterally, which means on both sides, that kind of helps elevate and protrudes the mandible. Whereas if you're just contracting on one side, it kind of helps with the opposite excursive movements. So if I'm contracting my left side, it'll help with excursive movements to the right and vice versa. Okay? And then here we're just, I want to make sure you guys are familiar with, like I said, the anatomy of this joint. That way when you're seeing a patient that has problems, kind of have a basic idea of what's going on, right? So just like we talked about the muscles, it's important to talk about what blood supply helps with the TMJ. So as you guys can see here, there's the superficial temporal artery and the superficial temporal vein. Okay, what's not pictured here is the masseteric artery that helps as well. And there's other arterial branches like the posterior auricular and ascending pharyngeal artery. But I want you guys to focus on that superficial temporal vein, as well as the facial artery and facial vein. And that's very important because oftentimes when you're doing surgical procedures for the TMJ, you're at risk of hindering that blood supply because it's very close to where your incision site is and where you're working. So if you're not understanding the anatomy, then that can lead to vascular issues for that joint. So this is just kind of showing an image of the nerves here. You guys don't have to memorize the exact numbers. I just kind of wanted to put this in for completion's sake so you guys understand where that facial nerve is and the proximity of where it is in comparison to the joint. And it just goes to show you that it can lead to a lot of issues if you're doing your incision and you're not cognizant of the anatomy, because you can lead to paresthesia of that joint. And as you guys saw on the previous slide, you can also lead to diminished blood supply if you're not cognizant of the vascular anatomy as well. Okay. Any questions so far? Like basic anatomy kind of makes sense a little bit? Okay, cool. So I included this stuff, but I was told yesterday that I'm not covering this. I think there's a Dr. Davis or something. He's going to do it next week. So I'll just skip over that real quick. And Dr. Perkins knows that these slides are not going to be on your questions or whatever, okay? There's just one part I wanted to go over because the TMJ is very involved with it. I want to get to it though. All this work wasted. Okay, so oftentimes when patients present with derangements in their joints, the TMJ, that can lead to what we call headaches or migraines. So sometimes it could be a neurological disorder. Females are very prone to it. It could be unilateral or bilateral, on one side versus both sides. And it can be associated with light sensitivity, sound sensitivity, nausea and vomiting. So it's just something to just kind of have in the back of your head. That way when you're evaluating a patient with TMJ, you understand that this is a common complication of patients that are constantly suffering from disorders in that joint, whether it's one side or both sides. So it's just important to have like a basic understanding of that. So the location of migraines, it could be in these following regions here, as you guys can see on the slide. And it's important to understand the quality of, the pain that you're having from the migraine or from whatever, is going on. It could be throbbing, it could be pulsating, the intensity as well. You want to make sure you categorize the intensity, how frequent it happens, how long it happens, what makes it worse, what makes it better. And, just as like practicing dentists or whatever, it's important to, when you're getting a patient history, these are just some basic things you want to make sure you're asking every patient. Even if they're coming in for a cavity that's hurting them, or they need an endo, or it doesn't just have to be oral surgery, it could be, whatever's going on. You want to make sure you talk about these things: the location, the quality, intensity, how frequent it happens, the duration, what makes it worse, what makes it better. So that should be on like every patient you guys are seeing. They come in as an emergency with a problem. These are things, that should be discussed with the patient, because it'll help them and it'll help you, like, whatever treatment you gotta give them. So some things that can be prescribed, for patients that have, migraines are basic acetaminophen or aspirin, analgesics. You guys don't need to know about the abortive ones, but it's just for completion's sake. You have triptans, and that can inhibit calcitonin G-related peptide. So that works by stimulating serotonin, and that's a neurotransmitter that's kind of found in your brain. And then that leads to reduce the inflammation and constrict the blood vessels, right? Because migraines are typically a neurovascular issue. And then that can alleviate the pain from the migraines. That's just a little bit of detail, but don't worry about that. Yeah.
When would you, sorry. When would you prescribe the abortive ones versus the?
It just depends on, like we talked about, on the intensity and on the frequency of it, right? So if it's something that's a little bit more intense and has been going on for a while, then you kind of want to go from basics to something a little bit more intense or stronger. Does that make sense?
Yeah.
Okay, so I'm not going to go into these here. Okay. So can anybody tell me what the definition of TMJ disorders are? Like when somebody says, oh, I have TMD.
Disorder?
Yeah, what is a TMJ disorder like in your head?
Like crip?
Huh?
Crip,
Yeah, that's part of it, yeah, that's part of it. But let's say I'm your patient, I come to you, hey, Dr. So-and-so, I have TMD. That's another thing, trismus, yeah. That, yeah. Okay, so there's the American Academy of Oral Maxillofacial Surgeons actually have a definition of it. So it's a collective term. The reason we're saying collective is because, just like Stu Dr. Sear mentioned, there's so many things that can fall under the umbrella of TMD. So that's why we say it's a collective term. It describes clinical problems, just like they were mentioning, that kind of hinder the function or like chewing, disturbs the musculature like we talked about, things of that nature. So it's a group of conditions, and pain is associated with the head, the neck, and the jaw. So when you're screening a patient for a TMD, these are, I know this might seem like basic, but these are things you kind of want to ask. You want to ask them about the pain. Are they having any headaches? Like Julian said, sometimes there's crepitus, right? So that's kind of noises in the TMJ. Certain noises of that joint kind of help you diagnose what exactly is going on. That's something we'll go in a little bit of detail here in a second. Does the jaw lock or catch when they open and close? Have they had any prior trauma to that area? Have they done treatment before? Because sometimes that'll dictate what you're doing, right? You don't want to jump straight into a surgery. Sometimes you could do something that's a little bit not as invasive, see if that helps. If that doesn't work, then you can kind of take it to the next step and go from there. So these are a patient that comes to you, you want to get a brief history like we talked about, and that'll help you kind of further diagnose what's going on. So like we said, anytime you're screening, you wanna ask these questions here. So oftentimes it's in the preauricular area, which is this part where your joint is, right? You wanna ask about the duration, whether it's minutes to hours. The frequency, is it intermittent, is it constant? Does it keep them up at night? How intense is it? Is it just, something that's on and off that doesn't really hinder their quality of life? Or is it something that kind of limits their function, whether it's chewing food or they can't speak normally because of how much it hurts when they open, they can't yawn, things of that nature. So if it hinders the quality of life, then sometimes you gotta give a little bit more aggressive treatment for that. Then you wanna ask about the quality of it, whether it's dull, aching, and then what makes it worse, what makes it better. That's always something you wanna ask the patient, right? So these are some of the disorders with the TMJ, and we'll kind of go into detail about each one here in a second. You have disc displacements with or without reduction, subluxation, which is a hypermobility disorder, inflammatory disorders, whether there's something going on with the synovial fluid or the retrodiscal tissue. And then just like any joint, sometimes there's a lot of wear and tear, right? Like people get knee replacements because of chronic osteoarthritis or hip replacements, things of that nature. Just like your knee, your hip, your elbow, this is a joint as well, so it's prone to osteoarthritis or osteoarthritis, like any joint. Okay. So I know there's a lot of words on this slide. The next slide, I'll kind of have a picture of everything that's going on, but I'll just go over this real quick. As you guys can see on the slide here, we call it an intracapsular disorder. Why? Because it not only does it involve that condyle, but involves the disc as well. So if you guys go back to one of the first slides that we had, it shows you like that basic anatomy, right? So you know where your disc should be, and you know where the condyle is as well. So like when you guys are studying for whatever, it's important to kind of have that anatomy on the side. That way, when you read something like that, it kind of makes sense to you when you see it. You see how the normal anatomy should be, right? So I want you guys to think about your mouth when you close, right? In the closed mouth position, where is that disc? So the disc, where should it be? Let me go back to that first slide. That's your normal anatomy, right? You see the disc where that red arrow is pointing. You see the condyle, right? Okay. So now let's go back to the slide here where we talked about what's going on. So yeah, get a good picture of that in your head real quick. So yeah, in the closed mouth position, the disc, it's anterior to that condylar head. So we saw it sitting right on top of that head pretty perfectly, right? In this situation, when you have disc displacement with reduction, that disc is anterior to the condylar head. Why is that a problem? Because sometimes it reduces the opening of the mouth. If you have a reduction in opening, that can lead to issues with quality of life, whether it's being able to yawn, speak, or just even to eat, bite into a bird or stuff like that. And then there can be sideways displacement, meaning medial and lateral displacement of the disc. That can also be an issue that goes on. And then, like they were saying earlier, you can hear some noises when you're opening and closing your mouth, like clicking, popping, snapping. That can occur with anytime you have disc displacement with reduction. So let's kind of look at a picture here, because I know there's a lot of words, so let's kind of see what's going on. So I want you guys to look at this image here where you had A, B, C, D, E, F, all that stuff, right? So what do we say in the closed mouth position? The disc is anterior to that condylar head, right? So look at here at A, the disc is anterior to that condylar head. That's the closed mouth position there. Okay, and then why is that an issue? Because it reduces the amount you can open and close your mouth. Okay, so some things to note, very important on a clinical exam. Could be asked like, hey, how do you distinguish, this from something else? On clinical exam, you have these three things on the bottom right? There's a normal range of motion. Sometimes there can be deviation on opening and closing. Can anybody tell me what deviation means?
Away from the midline?
Left or right?
Yeah, but there's a little more to that, right? So if you look at the arrow, like you were saying, sometimes it deviates towards the affected side. But when you open all the way, it comes back to the middle area, right? So like you open, it deviates over here, but then when you're all the way open, it's kind of in that center position. And then you can hear it click on opening or closing. So I actually have this displacement reduction. Anytime I open my mouth, there's a click and my jaw deviates, but it doesn't decrease my function. It doesn't affect my quality of life. I'm not having pain. I just hear like a little click anytime I open. So if that's the issue, if a patient comes to you with something like that, there's no reason to go in there and do a surgical procedure and have to worry about scar tissue and healing and all of that. If it doesn't decrease the quality of life of the patient, if it's not giving them pain, it's not limiting their function. Okay? How do you manage this displacement with reduction? I kind of just talked about that, right? So sometimes the best treatment is, just monitoring or no treatment, right? So if you have reciprocal or intermittent clicking without any significant symptoms, their quality of life isn't, really at stake here, then it's best to just monitor that area and make sure it doesn't get worse, have them follow up, and things like that, right? Now what about if there's issues with pain, they're having dysfunction? Do you want to go straight into surgery, or do you want to kind of try something that's a little bit more conservative before doing that? Yeah, so you want to try things like going to a general dentist to fabricate a splint. Sometimes that can help. You want to do behavioral modifications if it's one of those people, we see a lot of people that just constantly chew on their nails a lot, right? That's a behavioral modification. If you get them to stop some of their daily life habits, that can kind of help. There's also physical therapy exercises that can help. Appliances that can help you open your jaw a little bit more and help with closing. And then there's medications that can help as well. And that's a very important one. We'll go into a little bit of detail about that in a second. And then if you do that stuff and you want to trial for at least 2 to 3 months to see if their consistent conservative medication options are helping or not, right? If that doesn't work, then you can take it to a next step higher, which is arthrocentesis and some other procedures that we'll talk about a little bit more detail in a second. So we talked about disc displacement with reduction, right? So I want you guys to just kind of get a basic understanding of this slide here, what it entails, what are some of the clinical, factors that you can appreciate when you see somebody with reduction. And then now we'll talk about the other end of the spectrum, disc displacement without reduction. So we said it's an intercapsular disorder, right? Because we're talking about the condyle and the disc together. If you guys go back to that first slide, you see how the condyle and the disc are supposed to look, right? Same thing like with reduction, the disc is anterior to the condylar head. So those are kind of similar right there, right? It doesn't reduce when you're opening the mouth. That's something we'll talk about here in a little bit. And the most important thing is there's extremely limited mandibular opening. So I want you guys to look back at this slide here. If you look at this patient's MIO, meaning their maximum incisal opening, it kind of looks normal, right? Like 30, 35, something like that. That's with reduction. Now, if you look at it without reduction, one of the key differences is look how limited that opening is, right? So do you guys think that's something that kind of limits their day-to-day function or their quality of life, or not really?
Absolutely.
Yeah, right, because they're not able to open, they're not able to function pretty properly. So oftentimes you could see something called a closed lock, where they're in that position, they're not able to close back. So let's look at some clinical images that will kind of help you guys appreciate what's going on a little bit. So look at A. So look, yeah.
Can you explain what reduction is?
I'm about to go into that in a quick second. Yeah. So with reduction, meaning when you're trying to close back, there's something called a close lock that's kind of preventing that. So you're not able to reduce back into the issue. Okay. So if you look here, so look at A real quick. It's the same kind of start we said with reduction, right? So you have in the closed mouth position, the disc here, it's anterior to that condylar head, right? The issue is the disc, like you were saying, it doesn't reduce back into the position. It doesn't reduce back into that position. So that's what kind of, because this doesn't kind of click back into this area, you're not able to close, if that makes sense. This hindrance right here is preventing you from closing back to where you need to close. Does that make sense, or are you guys still?
Is that what makes it lock?
Yeah, exactly. Yep. Does that make sense, or am I confusing you guys a little bit?
So is this like lockjaw? Is this
Oh,
what they
yeah,
call it?
it's kind of the same. Yeah,
Yeah.
yeah. Okay. So if you look at your clinical images here, what do you guys think deflection is? And so it's important to know this here in bold, the differences between without reduction and with reduction. Okay. So if you look at here, limited range of opening, what do you guys think deflection is? So we talked about deviation, right? What's deflection?
Moving away from the side that has pain, maybe?
Huh?
Moving away from the side that has pain?
Moving away from the midline during opening. And the issue is, it's like, well, like we said with deviation, you move away from that midline, but when you're all the way open, it goes back to the middle, right? Deflection, you move away and you stay in that position. Why? Because like you said, it's a lock, right? Your jaw can't close back because the disc is not moving in the proper area. So movement away from the midline, with a return to the center, that's deviation. But movement away from the midline without return to the center is deflection. So that's one of the, you see a patient that comes in, you see that could be a distinguishing factor, and it helps you further diagnose the patient, right?
So this patient right here, does he have a issue with both condyles or just one?
Yeah, both, yep. Somebody else have yeah.
And they usually like come in with their mouths open like that?
Some of them, yeah. So I've seen it once where a patient comes in and they can't close back into that position. I've seen that once. So let's talk about, kind of management and how to manage these types of patients. Does that slide make sense though? I want you guys to kind of, these are pretty important slides, this slide and, this slide here. It kind of helps you distinguish that stuff. So I want to make sure like it makes sense.
Can you say one more time the definition for deflection?
Yeah, okay, so deviation, let's say you're opening your jaw and it goes to like the left while you're opening. So you're opening, it goes to the left a little bit, but then when you're all the way open, it comes back to that midline. So that's deviation. You're opening, it kind of slides to one way, the affected side, then it comes back to the middle when you're all the way open. That's deviation. Okay, so you can see here if you follow the arrow, pretend like this guy's mouth is closed, or this girl, her mouth is closed, she's slowly opening, it's moving over here to the side, but then when she's maximally opened all the way, it comes back to the middle, right? So that's deviation, you're coming back to the midline. If you look at deflection here, you're opening, but when you're at your point of maximal opening, you're staying towards that side, it's not coming back to the midline. Okay? So we have disc displacement without reduction and, in terms of management. So like we said, oftentimes there can be conservative therapies. So you want to advise the patient, kind of see what habits they have. You want to avoid them chewing and biting into hard foods. If they have parafunctional habits like tooth clenching, grinding, gum chewing, they're constantly biting their nails. Those are things you kind of want to omit in their daily lifestyle before you go into some kind of surgical procedure to help with that area. So basically, that's why you're asking what are aggravating factors anytime you're screening for a TMD patient, right? So you want to know what's going on in their daily life because we don't see everything. So it's important, that slide where we had talked about screening the patients, it's very important that you guys ask those questions. That way you know some of their lifestyle habits and see what they can cut out, see if that can help, You want to counsel the patient, have them control their jaw exercises, reaffirm like if they're yawning and opening their mouth all the way, or even when they're talking, that's kind of stuff you want to limit a little bit. Why would you want to consider heat application to that area? Why do you guys think that would help? Did someone say blood supply? Yeah, so that slide where we talked about the anatomy, right? So anytime you have that, going, it can stimulate, the blood supply, and that can promote alleviation of the symptoms of that patient. And then sometimes you can prescribe a course of NSAIDs for the pain control and the inflammation, right? Non-steroidal, anti-inflammatory, because sometimes these are inflammatory disorders that are going on, so you can prescribe that. And like we said earlier, you could do an occlusal appliance that can help, eliminate, if they're grinding their teeth at night or bruxism or whatnot, that can kind of help with that. If for whatever reason, you know, you do that and it's still not working, then you can go to the next step of surgery, of management, which would be arthrocentesis. That can help kind of improve the symptoms, increase the mouth opening, or different surgical procedures. And we'll talk about that in a minute, so don't worry about that for now. Okay. Okay, so now we have another, you know, issue that we talked about, a hypermobility issue, which is subluxation. Just by looking at the picture, can anybody tell me what they think that is? Just by looking at the picture, not the words. Exactly, yep. So you have very an extreme kind of hypermobile, very open, and not able to kind of, you know, close back. Has Dr. J talked to you guys about this before or no? Huh? Has he mentioned, you know, subluxation to you guys or no before? Because there's always like a little story he has behind it. But... Okay, gotcha. Okay, then I'm not gonna go over that. Okay, so as you guys can see on the slide, it's a hypermobility disorder, meaning you're open beyond the natural opening. It involves the disc and the condyle as well as the articular eminence, which is right here. Okay. So when you're opening the disc and the condyle complex, it's anterior to the articular eminence. So now it's not just anterior to the condyle like the other ones we just talked about. Anterior to this bony protrusion here, which is your articular eminence. So imagine if you're anterior to that, then you know you're going to be extremely wide open, and you're not able to close back because when you're trying to come back, you keep hitting this piece of bone here, that articular eminence. Does that make sense, guys? Yeah or no? Okay. How long can it be? It can be momentary. It can be very prolonged, and it's often perceived as an open lock, meaning instead of a closed lock like disc displacement without reduction, where you have very limited mouth opening, but you're still open in that area. This is an open lock where you're kind of open all the way and you're not able to close, because anytime you're trying to close, you're hitting this piece of bone, which is the articular eminence here. So sometimes it can develop in patients that have hypermobility disorders like Ehlers-Danlos syndrome or things of that nature. Does anybody know what the most common population of patients that kind of suffer from subluxation? Nigeria. So oftentimes you'll see it actually no, I'm not going to talk about that actually. Yeah, don't worry about that. So typically you'll see this a lot randomly in the middle of the night. You'll come into the ED, there'll be a patient that has something like this. So the way to do it is you have to do some kind of physical manipulation to that area in order to bring that condyle disc complex past the articular eminence and get it in the closed position. So you want to train the patient to restrict their maximum opening. So whether it's yawn and you want to counsel them not to open their mouth that big, whether they're eating food, to cut their food into small pieces, things of that nature. And I know it might seem like really basic stuff, but if you emphasize that to a patient, then that's something that they can follow in their daily habits. So how does it work? So basically you want to put your thumbs in the most posterior area on their mandibular arch, so meaning behind their molars there, and you're kind of pushing down a little bit as much as you can, and while you're pushing down, you kind of come backwards like this. Why are we pushing down? To get the disc condyle complex to go past that bony protrusion, which we said is the articular eminence, right? So if you go over here, imagine this whole thing is anterior to this area right here. So you want to push down, that way you're bringing this part lower than the eminence, and then you can bring it backwards to get it back into the fossa.
Are they awake when you do this?
Some of them, yeah. So I've done it only once in the ED, and the patient was awake. What helps me is oftentimes I'll anesthetize. I'll do a bilateral gout gaze where you're a little bit higher, and then I'll give some kind of anxiolytic to just kind of help a little bit, like Versed or something, and you can just do it in the ED.
It's not dangerous for physician fingers can bite you or something?
No. It's not dangerous.
Do they usually feel pain after, you put it back?
No, you don't.
Okay.
Yeah. And then that's why you want to anesthetize a lot higher up when you're doing it. Yeah. But tissue. So what are some inflammatory disorders of the TMJ? We have capsulitis, which is inflammation on the outer fibrous part of that capsule. Synovitis, any joint has synovial fluid, right? So sometimes there can be inflammation of that fluid. And then retrodiscitis, we have that disc, right? Sometimes the tissue around that area can be very inflamed. So it's just important just to know that there are, three kind of inflammatory disorders of the TMJ. One involves the tissue of the capsule. Sometimes it can involve the fluid in there, the synovial fluid. Sometimes it can involve that disc area, what we call retrodiscitis. Yeah.
How do you use Botox or fillers to kind of, I guess?
That's good. Yeah. So we talked. Let me go back to this slide for 1 second. What slide am I on? Okay, cool. So we talked about the muscles, right? So oftentimes when you're using, that Botox, you're, kind of inhibiting that presynaptic area, meaning that you're not able to contract your muscles as much, right? So let's say a patient is grinding their teeth all night, chronic grinding their teeth, they're constantly biting their nails or, things like that. Then they're overusing that muscle, right? It's like when you work out a lot, all you do is curls, you're overusing that bicep muscle, it's gonna kind of get a little bit bigger, it can be sore, things like that. If you're overusing your muscles of mastication or the muscles that kind of help with the TMJ, then they can, be in pain or be very sore. So things you want to do to alleviate that, if certain medications aren't working and behavioral habits aren't working, you can do Botox to kind of help with that. So that's actually something we do a lot at the VA, is Botox. And good thing you brought that up, because that's another type of treatment you can do.
So where exactly would you place it to kind of?
So what you do is, sometimes these patients clench a lot, right? So when you clench, it means you just bite down as hard as you can. So if you guys do that and feel your masseters, you can feel them kind of flex, right? If you bite down as hard as you can, put your fingers on your masseter, you feel that flex. And if you bite down as hard as you can, and you put your fingers on your temporalis area, you can feel that muscle flex as well, right? So what we have the patients do is I tell them, bite down as hard as you can, hold that bite, and I'll kind of palpate in that area. Once you feel the point of maximal tension, where they're clenching the most, that's where you would inject. Okay, so let's have a quick 10-minute break. And we'll be right back, guys, okay? Cool? What time is it right now?
8:45.
Okay, so 8:55 we'll be back. Cool? Okay, gotcha. Can I do it on my phone? Oh,
That's what I said.